Hi to everyone. I'm Dr. Amy Friedman. I'm the Chief Medical Officer of LiveOnNY New York, and I want to welcome you on this afternoon to the first of our 3 webinar series that we're calling What's the Deal with Diversity in Organ Donation and Transplantation? And I'm really pleased to have the privilege to introduce Lee Perlman, who is the chair of our LiveOnNY New York Board of Directors and is the president and executive vice president of Greater New York Hospital Association. And most of all, he is truly a passionate advocate for patients on the wait list. So Lee, take it away.
Thank you, Amy, and welcome to everybody in cyberspace, in Zoom world. You know, I didn't get a special background for today, so my radar room may not be as high as some of the ones I'm viewing, but please note that I am in my office in New York City, which is a kind of a sad, upsetting place right now. But I'm sitting in my office, so I have a plaque behind me. I don't have any pretty pictures. So this is minimalist, but seriously, thank you everybody for participating. And just by targeting in this afternoon, you're showing a commitment to the issue that we want to talk about. You know, it's well documented that communities of color face many challenges in all aspects of healthcare and really all areas of daily life. As a society, we need to do better. As a community that cares about people's lives and access to transplantation, we too can do better at ensuring that the color of your skin doesn't determine whether or not you can be placed on a wait list, receive a transplant, or live a long life after a transplant. As a first step, and we're taking the first step today, we need to openly acknowledge the challenges that exist and work together to ensure that we truly have equitable access to transplantation. So thank you everyone for being here today, because just acknowledging it is the first step. Some statistics that I think set the table. The United States Department of Health and Human Services Office of Minority Health reports that in 2019, 28.7% of all candidates waiting for a transplant were Black or African American. 40% were white. Of the 28.7% of the candidates were Black and African American, only 25.8% of that 28.7% actually received a transplant versus 47.6% of the white population that was waiting for a transplant. Those are very telling statistics right off the bat. While 28.7% of the folks on the waiting list are Black and African American, only 12.5% of organ donors were Black and African American, also a very important statistic. The number of Black African Americans on the kidney waiting list is almost the same as those who are white on the same kidney waiting list. We know Black and African Americans have higher rates of diabetes and high blood pressure, known to put them at risk for organ failure. And only 25.5% received an organ from a living donor versus 40% for white populations. So these statistics kind of set a table for this discussion. And I think the lecture series, which really came out of a discussion at our board and our foundation board, starts with the acknowledgement that we must and can do better. And we have to do more for communities of color. We have to have the opportunity to make a real difference in their lives. And we need to make it so that race is not a determinant of whether you're going to get an organ or not. So I really, again, thank everybody on behalf of the LiveOnNY New York board and all of our staff for being part of this inaugural seminar and webinar. So with that, let me turn it back to Dr. Amy Friedman, who will take you through the rest of the program. But thanks everybody for being here.
Thank you, Lee. So Lee really set the stage for us. And I just want to add one more statistic. And this comes from the US Census Bureau. that New York State has the second largest Black population of any state in this country. And the vast majority of those African Americans in New York State live in New York City and its surrounding counties. That is our territory, Live on New York, and I'll come to that in a moment. And this is why really the Live on New York Board of Directors turned to us at its last meeting, and when I say us, the Live on New York staff, and said, we need to do something. We need to take action. And that was the birth of this webinar series. So who are we? We are Live on New York, the organ procurement organization that serves, as you can see in the second bullet point, New York City, Long Island, and the lower Hudson Valley, 11 transplant centers, 86 acute care hospitals, and you've seen that we are the home of really the second largest Black population in the country. This is why it matters to us and why we really wanted to take action. So what have we decided to do, when, and how, where? We developed a series of 3 webinars. The first one, as you see today, is entitled Green with Envy. Skin color is linked to transplant outcomes. And we'll be talking about the transplant, the data and the background for how we really come to say that Blacks don't get transplants equally. Next week, at the same time, from 3 to 4:30, our webinar is entitled Black Lives Matter in Organ Donation. And there we'll be talking about what is different for Blacks about donation, many issues. And our culminating webinar, the 3rd week on September 24th, is entitled People of Color Need Transplants, Let's Cut the Red Tape. And that is really where we're going to be problem solving and trying to initiate some true and important action steps that are accomplishable and we hope will really begin to make a difference. I would like to acknowledge and thank the Live on New York Foundation, headed by Heidi Evans, their director, for the support for this webinar series. And I'd like to establish a few ground rules. These are not your typically worded ground rules, but I think they're appropriate here. First of all, we will of course have respectful discussion and perhaps disagreement, and that is invited. We want this to be an open table. We want our speakers to speak directly and not to feel that they must tiptoe around the issues, rather embrace them. We know that sensitive topics will be discussed. We are excluding politics from the table today. And if any missteps are taken by any of us, we need to address them respectfully. And for example, if I say something inappropriate, obviously unintentionally, I would like to be corrected in real time because that's what this is all about. Let's get it right. Finally, we want and hope to achieve some concrete identification of some concrete action items at the conclusion of this series. So with that, I am very pleased to introduce our first speaker of the afternoon, Dr. Kelsey Berry, who is a postdoctoral research scholar at the Harvard Medical School Center for Bioethics. And we came to Kelsey because she really wrote a very important, she was the lead author on a very important article last year in the American Journal of Bioethics entitled, Should a Lack of Social Support Prevent Access to Organ Transplantation? So I'm going to ask Kelsey to start on her topic, which is really a deep dive into how a patient is added to the wait list, expose the hidden barriers.
Thank you, Amy, and thank you, Lee. It's so nice to see all of you. I want to just take a moment and acknowledge that, the recent events, the pandemic that we're living through, these high-profile killings of unarmed Black people, they've been a moment, to pause and reflect for many people in this country in a lot of different ways. And there's a role for transplant to do that as well. So I really want to thank you all for being here first and foremost. If there are 2 things that I want you to take away from what I'm saying today, it's first that we have to be unrelenting about looking under the hood of our common practices. And we have to be crisp and clear about why what we find there in terms of racial disparities just can't stand. So let me start by echoing Lee. The issue of race and transplant is incredibly complex. And sometimes when I look at the data on transplant, it seems like the disparities are everywhere. So research has documented racial disparities impacting Black patients at each step of the transplant process, starting even from basic need to access to referral, to transplant evaluations, waiting lists, organ receipt, and outcomes, depending on the organ, or what I generally parse into 4 big categories. So disparity issues related to need, disparity issues related to the need to access transplant-related care, issues related to the distribution of a scarce resource, otherwise known as allocation, and issues related to outcomes. So how really can any of this be? The transplant system was not designed to consider race. In fact, far from it. And unlike many other parts of the US healthcare system, it's explicitly tasked with distributing a precious and limited resource, donated organs, equitably to the population in need while maximizing clinical outcomes. So with that mandate, it's built this remarkable system, which I'm showing you here, starting from a patient experiencing organ failure through referral, through waitlist evaluation, and then connecting them with the donors through interesting and evolving processes of matching them, and ultimately providing incredible aftercare to support patient and graft survival. It's not just build a system, but also a workforce that's deeply attuned to the value of equity, which is why I think it's so upsetting to know that despite these efforts, racial disparities continue to exist in the field of transplantation. So I think one thing that we've all recognized already is that it's not enough to just write race out of the rules of the system in order to address these disparities. In fact, if our progress reducing disparities in organ allocation has taught us anything, it's that we really have to look under the hood of apparently innocuous rules, which on their face have nothing to do with race. For example, the notion of allocating kidneys according to time spent on the wait list. Now, we saw how that blocked patients of color from the same opportunities that others have for organ transplantation. And by looking under the hood of that particular criterion, we were able to make real changes in disparities, like when we implemented the changes to the kidney allocation system a few years ago. These are the barriers to racial equity, the ones that are hidden in plain sight, that are under the hood of these common innocuous criteria that we really need to be tackling. And I'll say it's especially important early in the transplant process, because as well as we've done, and we have done, we've made some progress, which is remarkable, and we can talk about that later. But as well as we have done reducing transplant disparities in allocation and in outcomes, we can't have any kind of racial equity in the transplant system if we aren't letting patients of color in to begin with. So to tackle that issue, we need to journey to the part of the transplant system that remains notoriously hard to study, which is its fuzzy boundaries. This is the so-called black box where decisions and rules are being made transplant center by transplant center about who to admit to the system at all. And I'll suggest if we look hard enough there, we can find the barriers to racial equity hidden in plain sight. So focusing in on this black box, what do I mean by that? I'm sure many of you are deeply familiar with this already, but for those who aren't, I'll just say, this is the process after being referred for transplant that every patient in organ failure must go through in order to convince the transplant system that they're a good candidate for transplantation. So it's called patient selection for the transplant waitlist. Now, we know that Black patients are significantly less likely to succeed here and to be placed on the transplant waitlist. So recent estimates, for example, knew Black patients were 12 to 25% less likely than their white counterparts to be listed for kidney transplantation and had a 26% lower odds of being listed for liver transplantation. The data in heart and liver are not, I'm sorry, the data in heart and lung are actually not really available. I have been working on this for some time, have scoured the research literature, and there needs to be a little bit more data thinking about those other organ types. But from kidney and liver, we can start to draw some conclusions. So the other consideration, and this is from a recent study, is that once patients are listed, minority patients, particularly Black patients, are more often made inactive on the wait list when they're not eligible to receive an organ, and are likely to stay in the inactive status longer than white patients are. So going back to thinking about how patients get on the transplant wait list. So of the criteria that providers are using to make their patient selections, there's medical, financial, and psychosocial criteria. We now have pretty robust evidence showing that the last one, the psychosocial evaluation, is linked to Black patients being disproportionately excluded from the wait list. So, for example, Black patients are less likely to be listed than their white counterparts, typically due to psychosocial contraindications. So my research team, which spans a few institutions, we have people at Tufts, at Vanderbilt, and at Northwestern, was really curious about what was going on in this psychosocial evaluation, what was severely complicating and limiting access for patients of color there. We know quite a bit about the psychosocial evaluation. It considers patients' psychological and social suitability for transplant, combining assessments of their mental health and substance use histories, understanding and motivation for transplant, and the supports that patients are bringing with them to the system. So as Amy, I think, foreshadowed, I want to take you on a deep dive into the support piece, and specifically the requirement that patients bring social support to the transplant process. Roughly, social support refers to the care, services, and encouragement that individuals receive from their family and friend networks, which in transplant is considered extremely important to help with aftercare and recovery. Now, CMS has long required that patients' social support be evaluated prior to listing, but it's provided little other guidance than this. It just indicates that social support should be evaluated, but does not further flesh that out. So it leaves it to transplant centers really to determine what constitutes adequate social support, how to evaluate it, and how much to rely on this factor in their listing decisions. So with more than 250 transplant centers in the US deciding this in-house, you can see how it has become a black box that is desperately needed in uncovering. So together with the research partners I mentioned, we ran a national study with over 200 centers to understand how social support, which is this federally recognized factor in patient selection, is actually being used to determine access to transplant care. Some of the findings have already been published, but you'll be the first to see others, and to think together about how this seemingly innocuous criterion really does end up shaping the experience of patients of color in the transplant system. So just to lay the ground rules, we do know that the social support requirement is preventing patients from entering the transplant system. Providers surveyed report that they excluded on average 9.6% of patients due to inadequate social support, but there's huge variation from center to center, with some centers excluding 0 patients and others up to 20% of patients evaluated. And nearly half of providers use this criterion as an absolute contraindication to listing, whereas others consider it in a constellation of other criteria as a relative contraindication. We also know now, and have confirmed through surveys with providers, that these exclusions disproportionately impact vulnerable patients. And as some providers discussed following interviews with us, racial minorities. So you can see here, we did follow-up interviews with those who responded to our survey to dig deeper. And this is a provider who's discussing the fact that minorities, African-American individuals, their families have had it a little bit more difficult to satisfy their group's requirement for supports. It's just been more challenging for them to come up with a support network.
Kelsey, I apologize for interrupting. If anyone has their microphone on, could you please mute it so we can continue? Thank you.
That's fine, Carlin. As we kind of see how this has, this evidence has come together, there's a question here about why such a pattern of racial exclusion would emerge at the hand of a social support criterion. So I think for some of you, it will probably be obvious, maybe because in practice you've seen the criterion functioning. But for others, let's dig deeper for a moment. I'd like each of you for a moment to think about who would play this social support role in your life if you needed a transplant. It might be easy, actually. It's easy for me, but answer me this. Will that person be around to support you in 12 months or 5 years? And how do you know? Now, you might well have personal insight into the answer to this question, but how can you give an external evaluator confidence that this is true? So it might be easier if the relationship you have with your support person is socially recognized as stable. You're married, for example. Or it might be easy if it's what your evaluator is familiar with already. So here we see a social worker who's responsible for evaluating social support in the transplant setting, stating an expectation to see familial relationships coming into the clinic, and also saying that they're not going to trust other relationships, for example, those with neighbors or church members, to hold up in the transplant setting. It also might be easier to demonstrate social support if you and your support person present and communicate as clinicians expect. So that's true even though we know that differing communication styles are a common source of misdiagnosis and unequal outcomes for Black patients. Barring all that, you might be asked to go through extra steps, what we call demonstrations, to prove your social support. So you can see here the social worker is saying, if we don't have confidence right away, then we're going to ask more in order to verify that social support is present. And this brings me to my next point. So go back to that social support person you identified in your own head and answer me this. What would it take for that person to be able to spend 24 hours a day with you for 4 weeks or for 3 months? We now know that these and a variety of tasks of recovery care are common requirements for social support at a large number of transplant centers in the United States. So if you were worried at all about it being difficult to prove that your supports are sufficient and stable, or you wondered how your support person would get time off of work or shift other caregiving duties or have the financial security to relocate to live with you, then you're recognizing the various ways in which social support criteria limit access to transplantation. And that's, I think, even from the relatively fortunate place that I think many of us do occupy. Of course, some might be able to simply purchase support if they don't have it from their family. But not everyone has that opportunity. And consider this social worker who describes her patients of color, saying sometimes they come from very chaotic environments where the people in their lives may have drug problems, they're living hand to mouth. They're really just trying to manage their own lives, implying that they simply are not capable or don't have the resources to step in and be the support person that the transplant patient would need. It's not hard to imagine these circumstances, which are common in impoverished and strained networks, limit access for racial minorities, especially in the context of the longstanding racial wealth gap. Now, I just said a lot about social support, and there's a lot packed into that criterion. we can consider the variety of ways in which all of those factors converge to create adversity for patients of color trying to prove their candidacy for transplantation. So I already mentioned the wealth gap, placing disproportionate strain on social support systems of patients of color. But what about marital and kinship relationships or friendships? Are those really disparately experienced by people of different races? What we must remember is that these relationships are formed and function in a broader social context that has been tilted against Black individuals in the US for a pretty long time. So for example, economic marginalization and mass incarceration have had lasting effects on relationships in Black communities, including leading to a persistent and declining persistent gap in marriage rates, declining for Black individuals, while white people continue to have high marriage rates. Moreover, Black individuals tend to rely on smaller networks for their support. We see this in the sociological literature. And they have less chance to emerge from impoverished or risky networks, following on a long history of residential segregation and discrimination in the US. Finally, the subjective nature of the social support evaluation and the lack of guidance, honestly, from the evidence base or even from CMS makes this criterion a potential source of biases, which usually providers work very hard to leave out of their decision-making. So these factors all end up informing the experience of patients of color in the transplant system, and they converge to complicate access for them, contributing to the racial disparities at the point of listing that I described earlier. And this brings me to just the second major point of my talk today before I close. If we want to make a change on something like this, it's important to be very clear and crisp about why a change is needed and where we ought to prioritize our efforts. So there's a simple question to be asked, which is, why do we object to inequalities of any kind in transplantation? And I'll give you two answers. Well, first, we might object to these health inequalities because health holds special moral significance. It fundamentally impacts who we can become and what we can do in our lives. And the promise of a just society is to protect those opportunities equally. So socially, we cannot stand for the unequal health outcomes that we're seeing in transplantation. Now, second, this transplant system, as I mentioned earlier, was set up exactly so that we could all share organs. It seems to be the one area of the health system where we can all agree that these organs are not just normal medical resources that are bought and sold and paid for. They are these precious gifts to society to be shared and enjoyed equally. So by our own commitments entering into the world as members of the transplant community, we can't stand for the inequalities we see in transplantation. The harder question is, which health inequalities, including which of all of the racial inequalities in transplantation, are the most morally problematic? And where do social support mediated inequalities fit in? Here again, I think we have a clear answer. So those inequalities in access that are the most unfair, that patients, they're the ones that patients themselves did not freely choose, that stem from maltreatment at the hands of others and at the hands of our broader society. So we can be really crisp and clear about why the social support criterion in particular needs to change. It's not just that it blocks patients of color from participating, but it does so by allowing many and surprising corners of racial injustice in our society, mass incarceration, residential segregation, and economic marginalization of Black communities to determine their access to transplant care. And we certainly can't stand for that. So before I go, turn it over to someone else, I'll just introduce this idea that we need to be strategic in our disruption of racial disparities in transplantation. So for example, I am not advocating that we simply drop social support from listing evaluation, but instead that we use it to identify ways to help and not exclude patients of color to access the system. So I'll be glad to take questions later. I just wanted to leave you with this quick little schematic. This is a framework that I use often with the healthcare organizations that I work with in order to illustrate the continuum of steps that need to be taken in order to move from injustice to justice, and to help them locate where they are as an organization and move along the continuum together. I think this is a helpful way to think about where we need to go. And for each disparity that we find hiding in plain sight, to take the next reasonable step on this continuum to move towards racial justice. Thank you so much.
Thank you. That was really amazing. So I'm very pleased to introduce our second speaker, Brendan Parent, who is an assistant professor of medical ethics and director of sports and society at the NYU Grossman School of Medicine. And we've known about Brendan for quite a while, but he particularly came to fore now because he also wrote in the same bioethics journal in response to Kelsey's primary manuscript. So we're very pleased to have the opportunity to have Brendan speak to us. And his topic is ideas to, I like that, ideas to improve access and outcomes for the minority marginalized transplant patient.
Thank you so much for the introduction, Amy. I'm very grateful for the groundwork that Kelsey laid and inspired by her presentation, and jealous of her PowerPoint game. As very impressive. This will be far less exciting in terms of imagery. And also, this is going to be far less systematic. Kelsey has done extraordinary research, and I had the easy job in the articles that Amy was mentioning of responding. It's very easy to be a critic. It's much harder to do the systematic work. And I wasn't actually critical of the work in my article. I basically agree she said, and believe that it's time to figure out how to augment social support and not penalize its absence. So a lot of the ideas I'm going to be talking about here really are hopefully somewhat intelligently off the cuff, but still off the cuff. So let's get into it. Quick disclosure, my salary is significantly funded by a gift from United Therapeutics, which is a company that helps to bioengineer organs, among other things, and is attempting to do so, let's say. So first, a quick note that plays off of what Kelsey was saying, that mental illness and intellectual and developmental disability further complicate the notion of eligibility for minority communities. The proportion of minority populations that are suffering from mental illness and intellectual and developmental disability is no greater than the white population. But as Kelsey mentioned, the lack of standardization in how to consider these as contraindications leaves significant room for implicit bias from transplant centers to creep into the determinations of who should be eligible for listing. So for example, we might have two patients with the same limited social support network, and potentially both have mental illness or intellectual or developmental disability. It's possible that the person of color might be deemed ineligible, whereas the white person would not. Further support for this possibility is that in dialysis, Black patients, as opposed to white patients, are far more likely to be reported as unsuitable for transplantation because they are, quote, psychologically unfit. Additional factors like cultural hesitance to acknowledge mental illness or intellectual or developmental disability, which may lead to less effective support or management or care, or lack of resources to provide adequate care, might mean that individuals in this community with mental illness or intellectual or developmental disabilities might more often be deemed ineligible, again, because of implicit bias. So this requires, at minimum, that the clinicians and other individuals at the transplant centers require implicit bias training. And this goes beyond the basic cultural competence training that might be offered, so that these individuals can confront what we all experience, what we all deal with, which is our implicit biases that we must confront. But ultimately, I think this all comes down to the same concern, which is transplant centers not wanting poor outcomes leading to punitive measures from organizations like CMS or OPTN, which we'll talk more about. So what do we do about the issue about concern about poor outcomes? Well, improve the likelihood of compliance. Quick heads up, the following suggestions all require time and money and willingness from people who have power to make difficult decisions. So I recognize that there are many competing interests and needs at transplant centers, and that this is easy to say, but potentially hard to do. I also recognize that there is a significant proportion of populations that we are discussing who might be socially isolated and undomiciled and with significant comorbidities, for whom these ideas that I'm describing might not be relevant or possible to implement. And for these populations, we clearly need to address the fundamentals of access to healthcare, access to social support structures that are overlooked in this country. Final caveat, I'm a bioethicist. I'm not a healthcare administrator. It's possible that some of these ideas are just not workable and that the systems will just not allow for them. So I welcome critique and feedback in the hopes that maybe we could tweak some of them in addition to throwing other ideas completely in the garbage. So first off, this is not exactly rocket science. Social work support might be sort of the the availability of adequate social work support to help address racial injustice in transplant. Bigger centers that have more social work support can afford to transplant what are traditionally considered more risky or isolated patients. And if we were able to provide comprehensive social work support, it might actually involve things like regular house calls and checking in on patients via video call at significantly regular intervals. Or is it possible that a transplant center might even be able to hire a team of home health aides to literally rotate among the most vulnerable patients to meet the requirements that Kelsey was mentioning, i.e. 24/7 care for X amount of time. And that X amount of time might be a very long period of time or maybe forever. Is it possible for the transplant center to actually train and vet and certify home health aides in this way? Or what about the possibility of not the complete support, but additional support through a volunteer nonprofit, i.e. understand that the public, some members of the public like taking care of other people. Could we create a certification program for individuals who want to do public service, to do regular check-ins, medication drop-offs, accompany or drive patients to and from their appointments, or maybe even go to dialysis centers to provide a significant education information about transplant to those on dialysis? Now, I wonder, do any of you do volunteer work? And if so, is this something that you would consider as a volunteer activity in addition to Meals on Wheels or Street Squash or any of the number of other opportunities that exist in New York? I would personally. Technological monitoring. Technology has become extraordinary, right? Maybe we could get a clever startup to help address some of these issues. We already have smart pill boxes that set off alarms to let you know when medication needs to be taken. What about the possibility of these alerts actually being sent to social work so that they can then follow up with the patients, or have camera setups to make it easier for patients to take photographs of relevant parts of the body to look for risks of graft failure. Maybe these images can automatically be sent to the relevant clinical staff, heavily encrypted and password protected, obviously. And maybe also create alerts if the images are not taken, or have algorithms to be able to identify concerns. And this might even be integrated into the pillbox. Again, I'm just spitballing here. Now I'm gonna change tack here for a moment and talk about policy. For a significant period of time, one of the greatest concerns for transplant centers about transplanting patients that they consider more risky was CMS coverage, i.e. coverage from the Centers for Medicare and Medicaid Services in terms of reimbursement. Well, in 2019, CMS changed its requirements and no longer needs data reports, clinical experience, outcome requirements, and this was a long time coming. Centers ostensibly might now be less worried about losing CMS reimbursement coverage for transplanting patients for whom they think outcomes might not be as good. And this change was intended to allow for increased use of available donated organs and increased consideration of patients for transplant candidacy. So now we have a different concern, which is the OPTN Membership Professional and Standards Committee. All transplant centers, as you probably know, must be members of OPTN, and the MPSC monitors compliance with membership requirements. So its standards for transplant outcome success used to be on par with CMS requirements. And now with the CMS change, MPSC is now a bottleneck for flagging underperforming centers. Now, it's important to acknowledge that OPTN MPSC, I'm sorry for all the letters, has been trying various self-examination efforts specifically on this issue of equity and centers for small numerical differences in outcomes, which are, by and large, very good. So despite the CMS changes, this might prevent centers from pursuing transplant for patients they deem risky, which disproportionately affects minority populations. So it's time to call on OPTN and MPSC to make decisions about their reporting requirements. Perhaps they do away with them. And finally, here's a bucket of everything else we probably need to address. Health insurance, personal finances are obviously one of the biggest concerns. The ability to pay for long-term immunosuppression regimens. Well, how do we address that for patients who don't have health insurance or don't have adequate health insurance? Do we increase the cost of all transplant to subsidize those without insurance? Or maybe we need to create fund pools, and by we, I mean each transplant center, create fund pools specifically to cover those without insurance in order to provide for their medication and every cost that's necessary as part of the transplant, get philanthropic donors to help contribute to those pools. I'm sure these kinds of pools exist. And I put universal healthcare in there just because why not? Who knows? Maybe that's possible in a few years. I'm sorry, politics, stay out. We need to improve trust in the healthcare system, right? There's a ton of data that suggests persons of color, specifically Black individuals, are more wary of issues like donation, right? And they're likely to think that they won't be saved in an emergency if they have donor designations on their cards, and are also mistrustful of healthcare, and understandably, because there is a long history of marginalization and bias in healthcare leading to worse outcomes for individuals of color. So we want to improve their trust, but we also want to reduce the actual bias in healthcare, which leads to worse outcomes. NYU is piloting some trials of education campaigns in community centers, going into places like barbershops and churches and helping educate, learn about their concerns, and help endow community leaders like ministers and the barbers to help create some amount of culture change on issues like accessing care and trusting healthcare systems. The last item I'll put on here is referral from dialysis. So 70% of end-stage renal disease patients are on dialysis, and many of them claim they never hear of, and many of them never actually present for transplant. On dialysis, Black patients are significantly less likely than white patients to report receiving information about transplant. African Americans have 25% lower chance of waitlisting than white patients. Now, put this all in context of the fact that CMS mandates referral for transplant within 45 days of starting dialysis. Now, clearly, this is a business conflict of interest for dialysis centers. If patients get transplanted, they don't need dialysis anymore. So can we understandably trust dialysis centers to provide the information that they say they are providing about transplant when so many patients on dialysis are saying they don't remember receiving it? So clearly, we need to work with CMS to improve standards for education, maybe have separate entities be responsible for doing the education in those facilities. Maybe the nonprofit I mentioned could take on that role, providing education that we ensure gets to those individuals. So that's the last suggestion I'll put on the table. A lot of this, I understand, is half-formed, but hopefully substance or food for thought. And I do want to mention the references. Take a look at the very first reference we have there. If anyone wants to read Kelsey's piece, it's fantastic. And I'll stop there.
Thank you, Brendan. And if you can close your screen, and
Sure.
I will say, since we did have one request for references, we are going to make the references available to everybody following, not immediately, but we will get them to everybody following the webinar. So thank you very much. Our third and final speaker this afternoon is Dr. Devin John, and I have to tell you, it's a particularly personal privilege and pleasure for me. Devin and I have kind of grown up together and overlapped in many ways in our training as healthcare people and as transplant surgeons, and so I'm really honored to introduce him today. He is currently the Chief of Renal Transplantation at Westchester Medical Center, and Devin's topic today is disparities in living donor kidney transplantation. Can we improve our current state?
So nothing to disclose. I mean, as Brendan and Kelsey, spoke beautifully and well about this, and the whole issue of disparities have been a topic of discussion that has been in the transplant community for probably about 30 years or so. As for me, I was sort of like involved with the Minority Affairs Committee for quite a few years. And this has been a particular topic for me because of my practice. And I'm glad I'm sort of like the only transplant practitioner here, but it's good. It's fun. And it's quite clear that, end-stage renal disease is more prevalent and the incidence is higher amongst Blacks. And Blacks account for about 29% of the wait list. And the survival benefit has been clear, has been elucidated by two other speakers, showing benefits no matter who you are, improved survival. And as Brendan spoke so well about, is Blacks are less referred, less identified as candidates, and less likely to be listed within the first year eligibility, and receive 24% less likely to receive a transplant. Next case. Okay. So the sources disparity has been talked about. There's pre-referral issues from patient and provider, as well as income or where you live have an impact. There's once referred, there's a very complex system of navigation, which Kelsey spoke about, and There are many levels of difficulty during that process that are difficult to navigate. And once listed, there's the process of biological factors such as an increased percentage of B blood type amongst Blacks, O blood type amongst Blacks, which are the two blood groups that wait longest, and a variance in HLA polymorphism making matching more difficult. Then there are issues of allocation policies, which has been attended to by UNOS and the OPTN and CMS over the years to try and mitigate this process. There has been some improvement in mitigation over the years, but it's not all quite done. And the last part of it is limited living donor access. Next slide, please. And we'll talk about that. Next slide. Let's talk about the benefits of living donation. This is the graft survival benefits of living donation at 12 months and 24 months and 36 months. You can see that it's a very narrow band. You're talking about graft survival rates in the 95 percentile, no matter who you are, though Blacks do slightly less than those of whites or Hispanics, but it's really good. Next slide. And if you look at the patient survival overall, they have to explode this, the range on this to show that the 1 year patient survival and graft survival is far better, is really good. You're talking about in the high 90s percentiles at 1 year and even as much as 3 years. And these are far better than that of those for living donors overall in terms of survival. And that's where the benefit is. As for the donors themselves, next slide, the risk of the operation itself within 1 year follow-up based on the SRTR reports, which were recently published, show that the risks are low in terms of a donor, someone who's willing to donate a kidney to a loved one or just randomly donate to anyone. So the outcomes are very good as a result. But given all of that, we have a real problem. Next slide. Looking at the US living donor recipients by race since 1988 till more recently in July 30th of this year, this is based on the OPTN data. You can see that though 40% of the wait list, that's the current wait list, whites account for about 68% of living donor transplants, Blacks about 13%, as despite representing 29%, and Hispanics and Asians are reported in similar numbers. Next slide. So who are the donors? Majority of donors are whites. About 60 to 70%, 70% or so are white. And you can see that Blacks, Hispanics, Asians, so forth drop well below. Previous studies have shown that for Black patients, given all the potential donors they have, the chances of coming to finding an appropriate living donor is about 13%, while amongst whites, it's about 35%. So the question is, why are these numbers here and what are the limiting barriers that seem to affect Blacks or people of color? Next slide, please. So there are factors that are limiting. There are patient factors, that is both donor and recipient. There's physician and healthcare assistance factors, meaning pre-transplant, pre-referral, and the time of referral that have an impact. There's social networks in the community in which Blacks live, and there are financial impacts that seem to get in the way of this entire process. So we're going to address this on next slide, please. One of the key patient factors that affect Blacks more so than whites is healthcare literacy. Blacks as a whole have low healthcare literacy, and there's this knowledge deficit itself is across all areas in medicine, and this deficit impacts perception itself. One, not understanding the need for transplantation, how it's far better than that of dialysis, and the impact of and the superiority of living donor kidney transplant. There's oftentimes a denial of the disease and the severity of disease, and for many, the risk of surgery, they worry about the risk of surgery greater than the long-term risk associated with kidney with dialysis. And the data is quite clear that given dialysis, comparing dialysis transplantation is far superior. The outcomes for being on dialysis is similar to that of many oncological diseases like brain cancer or so forth. It's very poor compared to that of transplantation. Another factor that impacts living donation is the unwillingness of the potential recipient to approach family or friends to ask the question. And this has a significant impact. How it's very difficult for many to start this conversation to ask, would you or someone that I know or anyone that we know would consider donating a kidney? And oftentimes they are concerned, particularly parents, about their children being donors, the short and long-term risk of donation, not only physically, but financially in the long term, and how it might impact the ability to be hired or attain health insurance or maintain health insurance and the like. Oftentimes people feel guilty or feel that they may be inducing guilt or coercion of family members, particularly when asking someone who lives in the home in which they pay rent for or own, and this person is maybe a partial dependent. And sometimes there is a misrepresentation of the ask. When you ask a family member or a friend, the family member or friend may misinterpret how the question is being asked or how, if they're being demanded to participate in this process. Very, very difficult process. Next slide, please. Sorry.
It's patient factors.
Right. Next slide, please. So one of the issues that get in the way, in which Brendan and Kelsey spoke so well about, is the healthcare system, how it gets in the way, how we as practitioners create problems. And oftentimes, as Brandon spoke about, is the perception, the suitability, and the preferences for a living donor varies by race. Whites are more likely to be told about the options of living donation more readily than Blacks. And this impacts not only the rates of referral, but the access. African Americans itself as a whole get less education about the options of transplantation, particularly about the potential benefits of living donation. That starts at the outset in terms of the point of referral. Once referred, education at transplant center in itself can be a problem. The language used and the education material provided sometimes get in the way because of the limited health literacy of the potential recipient or family members. Oftentimes, physicians or practitioners talk down towards the potential recipient and their family members, and they're sometimes intimidated by this, and that in itself creates its own barrier. And it's not, and many times we do not provide sufficient information about the short and long-term impact about living donation, or what we do provide based on our requirements from UNOS, at least the OPTN, is sometimes so onerous in itself that we do not interpret what it means to the potential donor and the potential recipient as to what the impact actually means. Such as things sort of like, one of the things that's required in the policy is to say that if you're a donor and after donating, you may need to go on dialysis, which is interesting enough because it's such a rare event that a potential living donor goes on dialysis, that it's written in such a way that many transplant centers copy and paste the UNOS policy process without sort of caveat of explanation, to at least put it within the context of the rarity of this process. Another problem amongst Blacks is that, again, I discussed the high rates of blood type B and blood types O, which may limit participation in shared kidney donation process. I have many patients who are blood type O, and their family members are blood type B. Participating in the shared kidney peer donation process nationally limits that access, and that becomes a real problem in itself. Next slide, please. I'm going to talk about policy. Policy 14.3. This is a very interesting policy requiring the information provided to a potential donor undergoing evaluation to donate a kidney to a loved one or to anyone. And one program I know very well was cited for this. The education material, as well as the consent material, noted the following information. I decided to pursue donation out of my own free will. I am not being pressured or forced to donate my kidney. And I understand that I cannot receive anything of value, whether it's money, goods, or services,
Sure.
in exchange for a kidney. That was part of the educational process, as well as the consent process. Well, the OPTN, those evaluators came by and cited the program for using that language because it's required to use the following language, that it is free of inducement or coercion. When I presented the information of inducement and coercion to a potential donor, they had a difficult time understanding that. While when I combined both formats and made a hybrid process, they understood what I previously discussed. And that in itself sometimes gets in the way of the patients in terms of understanding the entire process. Next slide, please. Another factor is that who do we discourage from donation? It is not atypical that African Americans, particularly, and anyone of color, we have a higher incidence of the uninsured, undocumented, and foreign nationals, particularly in the New York area and many parts of this country, which are centers of immigration. The uninsured and undocumented are often discouraged, as well as foreign nationals. And part of it is part of the OPTN policy 18.5A, where data submission is required. And though the reason for the submission is to monitor potential donors and ensure safety in the overall, there's an unintended consequence. Because of our fear to be out of compliance and get a letter from the MPSC to meet these requirements, we tend to discourage use of the uninsured and undocumented because many of these individuals may not be able to meet the requirements for clinical follow-up, which is an 80% requirement, as well as laboratory follow-up, which is like 70% requirement. These individuals may not have the money or the time off from work to be able to come for these follow-ups over the ensuing 2-year period. Next slide, Peter. Another problem that gets in the way is our social networks and community. African Americans have low number of potential donors. Why? High rates of comorbid conditions. Chronic diseases such as diabetes, hypertension, obesity lead the way. Family members are very likely to have any of these conditions, since these are some of the leading conditions of leading causes of kidney disease or kidney failure in our patient population. Other factors that get in the way: social and employment circumstances. Many individuals are employed. They may not have the ability to get paid time off to donate a kidney and get the time off, whether it's 4 to 6 weeks or 8 weeks, to donate a kidney. That in itself becomes a barrier. There is also low awareness, which I spoke about earlier, about the option of living donor kidney transplants. And in studies have shown that though Blacks may be referred, they are less likely to complete the evaluation process for sometimes the same conditions that I mentioned above, and are less likely to receive a living donor kidney transplant, which was alluded to many times before. So my personal experience is very interesting. Given all potential donors for anyone, for all potential donors for anyone, it takes me I have to go through about 10 potential donors to one recipient to find one donor for a potential recipient. Overcoming barriers. Next slide. What do? We can educate our recipients, as discussed by Brendan. The other parts, to teach our transplant providers. We have to teach them, we have to be culturally competent. We have to get trained in these areas to reduce bias. We have to have a diverse staff to reflect the patient population, that speak the language of our recipient population and our donor population. Standardize the educational process and consider the uninsured and the undocumented and foreign nationals. And I can talk more about that later. Next slide, please. The policy itself should not be very specific according to the OPTN. It should meet the needs of our patient. It should be interpret the spirit of policy, and we should be able to do this without consequence. And we should also lessen the impact of post-donation follow-up. Many of our patients cannot follow up for many reasons. So compliance is a big issue in this case. And for financial, which I did not get to, sorry about that. Financial, which I jumped ahead, I'm sorry about that. Living donors, the expenditures for the operation is covered by the donor's insurance, the recipient's insurance, but doesn't cover lost wages, out-of-pocket medications, lodgings, meals, and the like. And Blacks are disproportionately affected by this and the unintended consequences of this entire process of regulatory procedures. The National Living Donor Assistance Programs, it does help in some ways, but the proof of income to meet the requirements is sometimes limited. It fails to address costs within urban settings. It fails to cover the lost wages, and it fails to cover foreign national donors, and it's a pay of last resort. To get back to the whole process of overcoming barriers, I'm sorry about that. Again, culturally competent training is important, standardized education, and considered others. Next slide. Lessen the impact of the policies itself, and use language that's appropriate to the recipient and donor. And financially, we need to come up with ways to cover lost wages. We've tried this through a program called Waitlist Zero. We lobbied New York State to try and develop a bill that may cover some of the costs overall. And in summary, we do have a lot of barriers, disproportionate African Americans. There are many sources of these barriers. We can take some corrective actions. One of the low-hanging fruit is to correct our policies locally within transplant centers as well as nationally, which may encourage and may reduce some of those blind spots that gets in the way of us listing and or considering living donors. Thank you.
Wow, Devin, thank you so much. What a great series of 3 talks. We have a number of questions, and I'll start with the one that I see Brendan is answering. But Brendan, maybe you can share broadly, verbally with us. Dave White's question was, are there any studies discussing whether the location of transplant centers contributes to basically to the color-based barriers?
So I'm going to be transparent here and say that I don't have the answer. I'm literally doing the lit search right now. But I can bet if I was a gambling man, I would say it would have a significant impact. And that's literally just based on all the information we know about access and opportunity. So I'm going to send one more citation here, and I actually just sent Amy the actual articles if you want to distribute.
Okay, thank you. Any of our other speakers have an answer to that?
Yeah, there's been studies that looked at urban transplant centers versus more rural transplant centers. And the more rural transplant centers have greater disparities in the entire process. Not only part of it is related to distance to travel to such centers, as well as policies and the impact locally in terms of the patient care and referral processes.
Okay. I view my job as moderator as to be a bit provocative, so I'm going to throw out a heavy question. Here it is. If there are lowered social support requirements or barriers to transplantation, and several of the speakers have spoken about the concern by transplant centers about focus on long-term outcomes. So if there is a lowered expectation and requirement for social support, because those outcome barriers, outcome requirements have been lessened, would that be an implicit acceptance of lowered outcomes being acceptable? And if that's the case, are we meeting our requirements to either deceased donors or to living donors to appropriately use their organs? I know that's a loaded question, but have at it. Kelsey, any thoughts?
I think I can jump in. Yeah, I think it's a really tough thing. That's why I called some of the practices that we have in the transplant system innocuous. I don't actually mean that they're innocuous. I mean that they're sensible. They make a lot of sense. There's a reason why social support is used as a requirement for access to transplantation. I mean, the aftercare is incredibly onerous, demanding. There are risks. In fact, sometimes, as Brendan alluded to, it's not just the period of time of recovery, but it's also the potential that a patient will suffer a very serious adverse effect and will require care and support for the rest of his or her life. So there are sensible reasons to have a criterion like that. And that's one of the reasons why my suggestion is not to lower the barriers and do nothing else. I mean, I think that we don't want to, that's kind of what I meant by saying we need to be strategic when we disrupt these disparities. If we simply lowered the barriers, there is a high risk that it would come at the expense and the sacrifice of the outcomes that this transplant system has worked so hard to optimize. We might be able to tolerate a slight reduction in those excellent survival rates, but we don't know how much of a reduction that would be, because frankly, the social support criterion is not evidence-based. We actually don't know how much of the transplant survival outcome it accounts for. There's no evidence demonstrating that. So we don't know how much we might lose if we just drop the barrier. So we can't go ahead and say, oh, we're willing to tolerate the whole gap that arises at the end of outcomes. But what we instead really need to do is say, no, we're continuing to be committed to the optimal outcomes that we've worked hard to develop. We're just going to think differently about how we're getting there, right? So we ask patients to bring with them something precious to the system, their friends and family. Are there other ways or other questions that we should be asking ourselves about what we need to build into the system instead of just assuming that that's fine? So that's, I don't think we need to give up on the promises that we're making to donors and the commitments that we're making in the system. We just need to start asking different sorts of questions and reconsider the assumptions we're making about practice.
Brendan, any thoughts?
I don't have much to add. I think Kelsey said it very eloquently. If we drop the reporting requirements for outcomes, it doesn't mean that we don't still require adequate support, right, or demonstration of it. So finding other ways to build this in necessarily, I think is actually absolutely critical. And you saw from my presentation, I think it's important to get creative about how to make support possible for those who don't have it.
Okay. Devin, I think this next question that's come from the participants is best directed to you. If I can get my pop-up messages to stop covering it. Okay. How can we increase donation among, and I think this is really living donation among Blacks when they are at greater risks for diabetes and high blood pressure?
And that's a very good question. We evaluate all potential donors, not on their history, their age, for evidence or any family history associated with diabetes and hypertension. Yes, Blacks are, myself included, at greater risk for diabetes and hypertension by doing glucose tolerance tests and looking at family history itself. Younger individuals we are oftentimes very cautious of, particularly if they have borderline hypertension or any evidence of family members or any glucose intolerance or any evidence of mild intolerance, and would not consider them. This is a problem, and it increases the risk in terms of long-term organ failure, meaning kidney failure, and or worsen hypertension after donation. It is a problem. We have to address that very carefully. We look at them carefully. We exclude individuals who do not meet criteria, but consider them, as best we can. And that accounts for a lot of the dropouts.
Okay, thank you, Devin. I'd like to introduce somebody else from the Live on New York staff. This is Sophia Rahim, who is our Director of Community and Government Affairs, and she's asked for the opportunity to make a comment. Go for it, Sophia.
Thanks, Amy. So as I was listening to Kelsey's presentation, and I was reading some of the comments that some of the social workers were making about determining you know, the socio or the social networks that are in place for Black and African American individuals. I sort of wondered if the issue was more so understanding what those networks look like in the Black community and placing more of a value on it, not looking at it through a lens of sort of a Western white perspective, but to understand what that means in the Black community. So just to give some brief history, right? So in a lot of Western African languages, the word for father is used for any elder in the community. There are women that will nurse each other's babies to establish that any woman who is older than you of your mother's age is your mother. If you fast forward to the African presence, the African first presence in this country as enslaved people, you know, it was very common for a family member to be sold, you know, to another family. And so if your mother was sold to another family, you were immediately adopted into another family. So as a people, we are very used to extended family and chosen family as being very tight and having a very close bond. So, you know, when someone says someone from my church is my support system, that's real. You know, there are people who will make rounds weekly, call you daily. And so that shouldn't be dismissed. When someone says a neighbor, you know, I think of my own grandmother. My grandmother has a next door neighbor that has not cooked a dinner in the last 10 years. Every single dinner she cooks, she brings my grandmother a plate. She has neighbors that will ring her bell. Mrs. Anderson, I'm going to the store. What do you need? So when people say these things, it's not, you know, it's just not, oh, my neighbor, when they get around to it, they're going to help me out. These are real bonds and they're very meaningful. And so I think if we took the time to understand the dynamics of that, I think people would understand that they actually do have a really good, strong support system in place.
Great comment. Thank you so much, Sophia. That's really food for thought. Let me ask another question now. I'm going to read this because I think it's just so right. It sounds like there are several potential ways to reduce racial disparities in transplantation and good reasons to pursue them. So why haven't we done it? Why is this problem so intractable? What really stands in the way of getting it done? Who wants to take that one on?
Last lawyer.
I can jump in.
Okay.
Maybe I'll try to be brief. You know, I think we've identified a lot of potential solutions. What we need to do is understand why things are the way they are. We've just described how they are and why they shouldn't be that way. But very few of us have gone into the process of why is it that our systems are the way they are? Why are we using these criteria? Where did they come from? How have they evolved over time? What comfort do they give the individuals who use them? So there's a missing piece to this lecture, which is understanding why people do the things they do. And some of the interviews, so that's the piece that I'm actually working on now with respect to the social support criterion. And it's really fascinating to see how providers who are very concerned about the social support criterion, who feel that it is unfair and who would prefer not to be using it, feel stuck. They can't change their practice. And one of the reasons being that they feel like they're at the bounds of their expertise, or they're at the bounds of the control that they have in the system. So understanding what those barriers are to changing the system is a key part here that we haven't touched on very much. But I'll stop there. There's way more to say, but I'll let someone else jump in if they'd like to.
Brendan, sorry, Devin, go ahead.
Many of the barriers are oftentimes based on our own perception of what we think is right within our environment. And that's often defined by our perception, not of ourselves versus the other. And the other is then sort of like placed in a, how should I go, a sort of like a perceptual process based on what we think they should be or what we think the other should be, based on what is our experiences are, oftentimes what is suggested to us on the broader cultural context, which gets in the way of how we actually do our job. We use quick thinking processes rather than thoughtful processes to look at each case individually and then take a good look at what's actually the underlying cause and effect, and how it impacts the patient outcome or how it impacts us. So we take the easy way out and sort of like write such an individual off, as Kelsey talked about earlier, and as we talk about, our social networks are not necessarily based on my individual nuclear family, but sometimes the broader context, particularly those individuals who are very involved with the church community. So we have to really look at that very carefully.
Brendan, did you want to say something?
Thanks, Amy. The only thing I'll add, in addition to the fact that I think all our presentations tried to grapple with all of the pieces that have to come together for change, for meaningful change, but I will point out and give some props to Rebecca Lynn Marshall, who in the comment box talks about the dearth of diversity in power, positions of power and authority. And that's something that I don't think we touched on. And that's something that needs to change. The transplant surgeons, the social workers, the heads of transplant institutes to change. And that's going to be a significant piece towards positive change.
Okay. I have one final question, and I'm going to give you each 30 seconds because that will bring us exactly to the end. We've talked about a lot of big issues. What really is the transplant community's responsibility and role here versus the greater, bigger community? Who wants to take that first?
I'll go, Amy. As being a member of the transplant community for more than 20 years, this has been a very difficult process. One, we need to really take a look at our practices. Many of the practices that we did were often guided rather by opinion rather than fact, and took a long time for some of the HLA criteria that used to dominate organ allocation to disappear. That in itself took many, many years to overcome. We need to move a lot faster to address these issues. These issues have been, the same issues have been discussed repeatedly in the literature for more than 30 years. And we've made some changes, but not enough. And we need to be honest with ourselves and really address the real issue, because the people who are most vulnerable are the ones who are denied the organ transplantations most often. And it is exceedingly telling that there's little or no information on heart or lung transplantation. And there's some information about liver transplantation. And that in itself is another part of the process that is affecting people of color.
Okay, Brendan?
I think it starts with the transplant community. They need to create access to information that is meaningful. And then once the broader community has access to that information, they need to do little things, the parallel to voting, right? You sign up to be a donor, right? You support recipients. I think those little things make huge differences, and potentially volunteer for the new nonprofits.
Kelsey, I'll get to you for a minute. I just have to point out, Brendan gave us a perfect segue to the second webinar, which is on donation-related issues. Kelsey, go for it if you have an answer.
Sure. So I just want to say, look, the transplant community did not create a lot of the disadvantages that people of color come laden with when they come to the door of the transplant community. But the transplant system is the one that receives these patients. And so their role is the role that they want it to be. There was a comment about the idea that maybe we do a race-blind approach, and that might be equal, but it's not equitable. Well, the transplant community has laid out its values in equity, and so they have to define a role for themselves that aligns with that. The one concern that I sometimes hear, and this is in the literature on organizations taking on a lot more than they typically would, is mission creep. So instead of thinking to yourself, we have to do everything, now we're going to fix all of the racial disparities that exist outside our doors too, look for partners. Don't try to take over the mission of other partners that are doing good work, but instead collaborate with them. So being open to that, I think that's part of the role that the transplant community can define for itself.
Wow, sorry, Brendan, you got 10 seconds.
Yeah, and the 10 seconds, I just need to acknowledge, I think it's important to acknowledge that 2 out of the 3 panelists are white, and we need to examine why that is, and hopefully for the next time we do this, make some changes to that as well.
What a fabulous discussion. I really want to thank all of our speakers, Kelsey, Brendan, Devin. I want to thank the Live on New York Foundation for its support. I think this is just a start, and I look forward to seeing you all next Thursday, 3 o'clock, to talk and find solutions to the donation-related barriers and disparities. Thank you, everybody from Live on New York. This was great, and enjoy the rest of your day.